Hi, I am Dr. Raman. I am a intervention cardiologist practicing at Asansol, West Bengal. Today, I'll be talking about latest update in hypertension. As per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributable to cardiovascular disease, which affects 45% people in the age group of 40 to 69. Raised blood pressure is among the most important risk factor for cardiovascular diseases. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow up. In India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively, as per WHO. Despite that, nearly half of the people of or 21% of men and 41% of women with hypertension were unaware of their conditions. Additionally, over 62% of men and more than 53% of women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide, according to WHO. International Society of Hypertension has released the 2020 Global Hypertension Practice Guideline. The inclusion of optimal and essential treatment paradigm attempts to address the issue that in resource poor setting. Optimal care refers to evidence based standard of care, and whereas essential standards refer to minimum standards of care to allow specification of essential standard of care for low resource setting. The American Heart Association and American College of Cardiology combinedly has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients who have low atherosclerotic cardiovascular risk. Among low risk adults with stage 1 hypertension, that is blood pressure between 130 to 139 and 80 to 89 millimeter of mercury, management starts with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacological therapy. Acute respiratory distress syndrome is a potential fatal condition involving lung damage, and experts often associate it with severe COVID 19 infection. A recent study, which appears in the Journal of American College of Cardiology, reported that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID 19 induced ARDS, as published by Journal of American College of Cardiology, September 2021. Lowering systolic blood pressure target down to 110 to less than 130 millimeter of mercury range substantially reduced cardiovascular adverse event in the STEP randomized trial, affirming the sprint finding for older patients in Chinese population. Among more than 8,500 patients of age between 60 to 80 in China, the intensive target trimmed 26% of the composite cardiovascular risk finding. From now, a second major trial supporting a lower target could unite the guidelines, which even among US professional society ranges from threshold of 130 to 150 millimeter of mercury. With regards to Prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure. The 2018 European guideline on the management of arterial hypertension recommended that the diagnosis of hypertension should not only be dependent on office blood pressure measurement but also on out of office measurement such as continuous arterial blood pressure monitoring or home blood pressure monitoring. 24-hour and nighttime BP measurement were associated with greater risk of mortality and composite of CV outcome. Thus, they may be considered as the most relevant measurement for estimating cardiovascular risk. For every 20 to 10 millimeter increment of blood pressure measured at night, the risk of mortality increases by 23% and the risk of cardiovascular event by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommend five class of antihypertensive drug considering high non-adherence treatment. The importance of combination treatment is particularly highlighted to improve adherence to therapy and blood pressure control. Therefore, the 2018 European guidelines recommend, especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed dose combination of ACE inhibitor or ARB plus calcium channel blocker or diuretic. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of known carcinogen, namely N-nitrosodimethylamine, that is NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by WHO, International Agency for Research on Cancer, to be carcinogenic in humans. If 1 lakh patients could have received NDMA contaminated valsartan from Zhejiang, Huahai, where the manufacturing site at the highest level of contamination were found every day for 6 years in the highest dose, it could result in 22 additional liver cancer over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. Valsartan recall accompanied by significant increase in the rate of emergency department visit of more than 6%. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable risk reduction. The largest study in including the total of 19,084 hypertensive patients during an average follow-up of 6.3 years. 1,752 participants experienced the primary CV outcome. An ambulatory BP measurement was performed for 48 hours to collect data on low BP deferred during sleep. The relative risk reduction for CV events was significantly improved for nighttime treatment when compared with awakening treatment. Thank you.